morning. Can I share my screen?
We can see you, Dr. Narang.
Great. I'm just going to share my screen, so hopefully I have sharing rights. Okay, if you wouldn't mind just disabling the participant screen sharing, and then I'd be able to share my screen.
So Dr. Narang is a internationally recognized sleep physician. She's a previous director of the sleep lab at Sick Kids and now has taken the leadership role in equity, diversity, and inclusion. She's my own personal mentor when I was doing my sleep medicine training, and still a mentor now who I do go to with challenging clinical cases, and I really appreciate her insights and help. So, without delaying this further, I'd like to introduce Dr. Narang. It's a pleasure to have her speak today.
Thank you very much for inviting me to speak, and I really enjoyed your talk, Dr. Bowler. It's always great to see the insights from the community as well, and I just want to add that I've learned a lot from you as well about how things work in the community. And I can tell you from our perspective at Sick Kids, it's been an asset to have you in the community. And I want to thank you and your lab for all the work that you've done in these past few years. So I'm just going to start by talking today about the therapeutic approaches to obstructive sleep apnea in pediatrics. And hopefully you'll see how things have really evolved with regards to how we think about approaches to OSA. So I just want to make sure that everybody can see my screen and hear me okay. Yes? Great, okay. I have no conflicts of interest. And so today I'm going to talk about the current epidemiology of childhood OSA, and Dr. Bowler has already talked a little bit about that, but I really want to talk about how the scope of pediatric OSA has changed. I'll review the current therapeutics for OSA in children, but my emphasis will be on persistent obstructive sleep apnea. So that's OSA after adenotonsillectomy. I'll discuss some of the challenges of OSA management in children. And really my focus will be these therapeutics beyond CPAP for OSA in children, which has really been my research focus for the last few years. So Dr. Bowler's already mentioned this as well, but we know that traditional pediatric OSA, and certainly when I started on my journey in sleep medicine, these are the children I saw. So traditional OSA occurs in 1 to 4% of all children with a peak age of 2 to 8 years of age, which really coincides with peak adeno and tonsillar growth. And I think over the past few years, we've really begun to understand the risks for having obstructive sleep apnea. But luckily for these children, and actually for us, adenotonsillectomy in this otherwise healthy population is curative in about 80%. But really, and I would say, in the last decade, we've really begun to understand the different epidemiology of obstructive sleep apnea. So what I really want to talk about today is the children with obesity, as well as children with underlying medical complexity, and really change the scope of the work that I do at Sick Kids, but I'm sure also the children that you're seeing in the community as well. So I'll start off with obesity, which we now recognize that obesity has significantly changed the scope of a pediatric OSA, and it doesn't just occur in the older ages, which is what we had thought originally. The OSA is really, obesity-related OSA is really occurring across the age span. I saw a 3-year-old in my clinic just about a month ago who weighed 65 kilos. So the BMI was off the scale, so it's occurring at a very young age. And it's very hard to predict which obese child will have OSA, but we know the prevalence is around 25%. It's probably a little bit higher in children who are younger, and around 25% in our adolescents with obesity. I think one of the things that we are also acknowledging is that 70% of obesity-related OSA will be not recognized, or should I say also untreated. And unfortunately for these children, the adenotonsillectomy, so the surgical cure, is only effective in 30% of children with obesity, and it's also hard to predict which children will be cured from an adenotonsillectomy. And as a result, CPAP is the most commonly prescribed therapy. So I'll just talk a little bit about that as well shortly. And I think something to remember for us as pediatricians, but also for our adult colleagues who are now seeing these young adults, that 70% of obese children will seamlessly transition to adulthood as obese adults. And what that really means is they are not losing weight or significant weight in childhood. And then the second group, which we have remained concerned about for a very long time, is the children who have very high prevalence rates of obstructive sleep apnea and continue to have very high prevalence rates of obstructive sleep apnea after adenotonsillectomy. So here, 70% prevalence in children with craniofacial orders, 80% occurrence of OSA in children with Down syndrome, 40% in children with sickle cell disease, 40% in achondroplasia, 50% with Prader-Willi, and as you can see, you know, other craniofacial disorders here, Pierre-Robin, 50%, neuromuscular disorders, 40%, and then metabolic disorders are 50%. And these do make up, as long as the children with obesity, probably now 80% of the children that we'll see at Sick Kids. And of course, as I just mentioned, there's a significant number of these children will have persistent OSA post-adenotonsillectomy. And why does this really matter? So, you know, I think all of us have recognized more and more with time is that, you know, we originally thought that the adverse consequences of OSA were more in adulthood who had a long-standing, particularly untreated OSA. One of the things that we really heightened awareness about is the neurocognitive issues or deficits associated with children with untreated OSA, particularly hyperactivity, disruptive behavior, emotional dysregulation. And certainly through the COVID epidemic, but even before that, depression, anxiety, and lower quality of life for families who have children with OSA has become more evident. And again, you know, we always thought that the cardiovascular and metabolic disease related to OSA was related to adulthood OSA, but in childhood now, even in younger children, there's increasing evidence of blood pressure dysregulation, arterial stiffness, and of course, insulin resistance. I think actually one of the most alarming papers I've actually read is that in this study taken out of Denmark, published in 2020, it showed that childhood OSA was linked to excess morbidity, not just in childhood, but in adulthood as well. And the mortality rates were 7 times that of children who didn't have OSA. So that's 7 times mortality risk in adulthood. Which I think you can all agree is quite astounding. And I mean, there's more evidence around this, but this was one of the first papers showing the risks of childhood OSA. And so a little bit about the approaches and the management of obstructive sleep apnea. So I think we're all beginning to understand this cycle. So after adenotonsillectomy, when many of these children will have persistent OSA, and that's not just in PSG findings, that is symptomatic as well of OSA. They're prescribed CPAP, and then we enter this cycle whereby at first pass, easily 50% will be non-adherent to CPAP. And that's certainly reflective of my population. And then we introduce behavioral therapy, rewards, we give them strategies for weight loss, they promise weight loss. And after all of that, we reconsider CPAP, and then actually it really hasn't changed this number, that 40 to 50% will remain non-adherent to CPAP. I'll pause just to tell you a really interesting story that I had an adolescent who refused to wear his CPAP, and in terms of rewards, it was a bribe. I offered him $1 a day for the 1 month if he wore CPAP. And at the end of the 30 days, his mum calls me and says, He's fully adherent to CPAP, and I looked at his download. He was wearing his CPAP 7 to 8 hours a day. He hadn't missed a day. So he got his $30. He never wore CPAP again after that, and told me he would only wear it if I continued to give him money. So it's interesting that, you know, some of these children can wear it, but obviously also choose not to wear it. So we undertook a study just to try and find out a little bit more about, you know, what were some of the differences in the children who will wear it and who will not wear it. And in this study with just over 100 children, we looked at and compared independent PAP users to dependent PAP users. And just to define it, independent PAP users in this mostly adolescent population were adolescents who handled the CPAP themselves and didn't have caregiver input. And the dependent PAP users were the ones where the parents did help them, whether that was putting on the mask, cleaning the machine, and so forth. And there was no real differences between the two groups, other than that BMI was higher in the independent PAP users. But I think what you can see here, those that were left to do CPAP by themselves, only 43% of those used PAP for 4 hours per night, compared to 61% who had caregiver input. So this got us to thinking that even though these adolescents want autonomy, that maybe caregiver input plays a key role here. We then went on to do a qualitative study where we actually asked these adolescents who had ranges of CPAP adherence, you know, what is it that you want? How can we help you? And then I think, as well as all the standard things that we know about, the mask was too tight, they didn't like it, made them feel claustrophobic, they didn't like the tubing, there's water in the tubing, all of those things we hear about. They actually asked for more parental help. And when we said, you know, what does that look like? We had, you know, adolescents saying, you know, my parents just need to clean the machine and add the water, with others saying, I want my parents to come into the room and remind me to put the mask on. So really a range of responses, but really asking for parental help. And then a lot of these children also said they don't perceive the benefits of wearing CPAP. And certainly this concurs with really big data as well here. So this was a study conducted by Rakesh Bhattacharjee out of San Diego. Some of you may know him. He was actually a sleep physician at Sick Kids in Toronto for a while before he moved to the US. And he looked at more than 20,000 children, PAP adherence data, who were like a mean age of 13 years. And again, they used the cloud database of PAP usage, and they looked at PAP usage over a 90-day period. And here what they found was that, very similar to our data, that only 61% used PAP continuously over 30 days in a 90-day period. And actually, only 43% used PAP for 4 hours for 70% of nights during the 30 days. So, you know, pretty low adherence. And when they looked at the factors that was associated with increased PAP usage, if adolescents were enrolled in engagement programs, if they were slightly younger, and of course, not surprisingly, if there was lower residual AHI and lower pressures were associated with increased PAP usage. So although these help us think about some of the strategies, it's still, you know, a little bit disheartening to see how low PAP adherence is here. And, you know, subsequently, we've really thought about targeting CPAP support using CPAP checklists. And so in our clinic, you know, we'll really talk both to the child and caregiver and really think about their motivation and their buy-in to use CPAP. And now we always really combine the caregiver and child together, and through the checklist we say, okay, what is the child going to do? What is the parent going to do in terms of applying CPAP at night? And we do, where possible, offer or think about rewards and incentives that is individualized for the child. And we continue to review the download data non-judgmentally, and our respiratory therapists will meet with all of these children repeatedly to adjust the pressures and consider mask fit. But I think we've, one of the things that, again, we've noticed is that that isn't enough. There needs to be other work done outside of clinic, particularly targeted at behaviors. And, we have just recently introduced a new research trial where we're actually randomizing our patients to peer support groups versus mindfulness-based interventions, in the hope that this will help promote CPAP adherence. So we don't have that data out yet, but I think we're recognizing that what we're doing just alone in clinic is probably not enough for this population. And then just again, in thinking of CPAP adherence, one of the other things we have to think about is that our goal is to get them onto CPAP in pediatrics, but our other primary goal is to maintain, or should I say sustain, CPAP adherence once they enter adulthood. And in 2014, with Dr. Claudia Ryan from Toronto General, and she's as many of you know, she's a sleep physician there, we set up this pediatric transition program between sick kids and Toronto General. And we did that because we found, regardless of CPAP adherence, only 38% of children young adults that we had transitioned to Toronto General actually attended their sleep clinic appointments. And we didn't really know why, although some of us had told us that once they got discharged from sick kids, they thought that meant they were discharged from having OSA and therefore didn't need to see us again. So subsequently, as you can see here, we set up this transition program here, which was quite a comprehensive transition program, where we really discussed, what CPAP was, education. Pediatricians and adults were present on the first appointment during the transition. So there was really formal handover of the care of the child, including PAP adherence and assessments. And I just want to show you that, we were quite pleased that we were able to set up this transition. And certainly what we noticed very soon afterwards, that there was an increased attendance at these clinics. But probably what I want to highlight here, and I hope you can see this screen, and this is data just again published by our pediatric to adult transition program here, that in the first 44 patients that transitioned, as we transitioned them here, the average PAP use in days used, and that's the hours per night, was 5 hours. By the time the 6-month follow-up appointment in the adult sleep service, it was 3.7 hours. Very disheartening. At 12 months, it was 2.6 hours. And this is despite having quite intensive follow-up and being part of this program. And although it's really hard to really disentangle what the causes are, we know that as youth are transitioning to adulthood, they're also transitioning maybe away from home, entering university, and their priorities have changed, and they don't have the same caregiver input. So disheartening to see that even for those that were using CPAP, it does fall off. And this is just in the first 12 months after transition to adulthood. With this in mind, we also thought that we should probably investigate what happened during COVID, as we were, as many of you know, during COVID, like one of the first statements to come out really was, it's aerosol generating procedure. CPAP was, and maybe we shouldn't be using it because of the risk of cross-infection for those with COVID, or increasing the risk of COVID in families. So we took the first 149 kids here, and maybe I can try and explain this a little bit more. We're trying to build a story about what happens to CPAP adherence, not just once we've prescribed it, what happens in adulthood, and what happens with changes with time and in different situations. And so, as we all know, COVID-19 pandemic was a unique situation. So we took these data from 149 children, and you can see here that many of them were in early adolescence. There was a high body mass index, and many of these children had been wearing CPAP for a few years. And of these, about a third were considered independent PAP users. Diagnosis was pretty much either underlying medical conditions and obesity. The majority of these kids had obstructive sleep apnea and were prescribed CPAP, although you can see here, many were also prescribed bi-level PAP. I'm just going to pause here, and I'm going to ask the group here, what do they think happened during COVID? Any thoughts?
I would say everything getting worse.
Yeah. Any other thoughts?
It got better.
It got better. Okay. Other thoughts? Okay. So actually, you're both right. So what I'm going to show you is, we looked at 4 consecutive time periods. So we looked at this, I don't know if you can see my arrow, before lockdown. Many of you may not remember the time before lockdown because it seems hard to remember, right, normality, but it was leading up to March 16th of 2020, and we went into lockdown in Ontario, and then we had a period of lockdown until June the 14th. We then entered a summer period, or should I say the school summer period, and school resumed on September the 14th. So we looked at these 4 time periods, and this is the percentage of days that CPAP was used. So before lockdown, you can see it was 60% here. And then look what happens during lockdown. It actually goes up significantly. And by the way, this kind of change isn't even seen in randomized controlled trials where they have behavioral interventions. That was a significant increase during lockdown. And then look what happens as soon as we enter the summer period. There's a significant drop from the initial baseline and during return to school. So that's over a 12-month period. And you know, we don't know the exact causes why. We do know during lockdown, there was more opportunities to sleep. There was later times if you were doing online learning, parents weren't rushing to leave the house. And that might be the reason. And I think as soon as there was relative freedom during the summer and return to school, CPAP wasn't as habitualized, and therefore it wasn't used as much. And by the way, the same pattern was seen in the nightly usage. And so I can tell you now that these data collection ended in December 2020, but we have not really seen that recovery back to the baseline before lockdown. So CPAP usage continues to be problematic in this adolescent population. And so I just want to summarize here about CPAP. Which I've really talked about, that it's suboptimal across all ages, and children with medical complexity seem to have better adherence than other children, and that we're not really sure of effective strategies to further increase CPAP adherence and also to sustain them. And again, why is that important? It's because many adolescents will transition to adulthood with untreated or undertreated OSA. And I think quite simply, right, I know at least one of my adolescents has sold CPAP on eBay. I think they've got other things going on and CPAP is not a priority. And so I think one of the things that is really important for us to consider is that, can we try and cure OSA in childhood using other approaches? Because a one-size CPAP fits all approach is not valid in pediatrics. And I think we have to remember, CPAP was never designed for children. It was designed for adults and just translated into care for children. So I think recognizing all of the factors that I've talked about, that CPAP is not necessarily the valid approach, adverse consequences of OSA, the additional burden on sleep specialists with all of this untreated OSA, and that now we're recognizing that in adulthood, those with OSA have lower educational levels, lower employment rates, lower income, higher healthcare costs, higher morbidity, higher mortality. We need to do something more definitive whilst these children are under the care of the pediatricians. And so I want to talk to you about some of the other therapies for obstructive sleep apnea. So I've talked about CPAP. I'm going to talk about bariatric surgery, hypoglossal nerve stimulation, drug-induced sleep endoscopy, high-flow nasal therapy. So as probably some of you know, conventional weight strategies, so asking a family and children within the family to lose weight, like those strategies have not changed the trajectory of the obesity epidemic. And here's a study published in the New England Journal of Medicine in 2016, and this was a multi-centered study in the US. And the mean age of this group was 17 years of age, and these children underwent bariatric surgery. And after 3 years, you can see here there was an astounding 41 kilo weight loss. And I think, as well as that being a significant weight loss, look what happened here. Of these 272, 95% had remission of type 2 diabetes. So morbidity rates from diabetes already significantly lower. 74% remission of elevated blood pressure. 66% had remission of dyslipidemia. And of course, very importantly for these children, quality of life improved overall. Now, this study didn't look at what happened to OSA rates. I think, again, you know, like OSA has not necessarily been on the radar as a significant complication of obesity, but these are pretty impressive data. And when they did a follow-up study, and again, this is just a small group who's undergone bariatric surgery, again, with significant weight loss and a decrease in BMI. And you can see here, after just 1 year, 2/3 of this group had resolution of obstructive sleep apnea. And I think that we do have a bariatric surgery program at Sick Kids now. And in the last 2 years, the only 3 children that have come off CPAP are the ones that have gone through the bariatric surgery program. And so we've started to really advocate for the child with significant OSA and significant symptoms to really be considered for bariatric surgery sooner than later. Of course, taking into all the other psychosocial impact of bariatric surgery and also the complications, but that maybe we should be advocating more for bariatric surgery as a first line of treatment for some of these children who have very resistant comorbidities related to obesity. I'm not going to really talk about bariatric surgery much more, but I just wanted to put it on the radar that it really is helpful in not just losing weight, but resolving OSA. I then wanted to talk a little bit about drug-induced sleep endoscopy. I don't know how many of you are familiar with this, but this is a nasal endoscopy performed during sleep. And this is used using a pharmacological agent called dexmedetomidine. And dexmedetomidine doesn't have the same respiratory depressant effects as some of the anesthetic agents. And so it's used because it is thought to be induce more a sleep-like state. And so during this procedure, which is done in the OR by our ENT colleagues, as they do the nasal endoscopy here, they can identify the sites of obstruction. And the great thing about identifying the sites of obstruction is that they can then target these for surgical interventions in the same anesthetic. And there's multiple sites of obstruction identified through drug-induced sleep endoscopy: inferior turbinates, nasopharynx, the velum, lateral pharyngeal walls, tongue base, lingual tonsils, and supraglottis. And I can tell you that we are using this here in Canada, but it is heavily now utilized, even as a first-line tool in the US for children with obstructive sleep apnea. And so some are using this actually to say, okay, they need an adenotonsillectomy for sure. let's do a drug-induced sleep endoscopy at the same time, just to see if there are additional sites of obstruction as well. So here's one study, and like I said, there's multiple studies, but maybe I'll just focus on this one because I thought this one was quite interesting because it involved overweight and obese children. So it was 40 children here. 23 here had never had an adenotonsillectomy, and 17 of the 40 had had an adenotonsillectomy. As I've mentioned, that the majority of these were overweight, obese, and many of them also had underlying medical complexity as well. And what they found, and they, so they did the procedure, they looked at the sites of obstruction, and then they did surgical interventions, and those are multiple. They could have done one surgical intervention or they could have done multiple. There was a range, but maybe I direct you here that here's the OHI here on the y-axis. This is the pre-op data compared to the post-op data. So there was a significant reduction in the OHI here after surgery. There was also significant improvement in the oxygen saturation index, the oxygen desaturation, but not an improvement in the oxygen desaturation index. Was probably a reflection of quite a small sample size and the power. But what they found here, that overall there was a significant reduction in the OHI, and that reduction was actually higher, again, probably not surprisingly, in those that also had an adenotonsillectomy. And so just showing that, it does work. What we have to probably understand is there's probably a group of children who this is more effective in. And I do know that there's a large randomized control trial going on in the US at the moment to try and identify which children are most likely to benefit from that. And I was just on a call with some of my ENT colleagues in the US who said they actually said no child should get CPAP without undergoing drug-induced sleep endoscopy first. So that surgery should be the first line just to see what is possible. And they also believe that actually for those that will need CPAP afterwards, that CPAP becomes easier because they've eliminated any sites of obstruction. I then want to move on to heated high flow nasal cannula therapy. I don't know how many of you are familiar with this. I'll just describe it a little bit. It's an integrated flow generator that is actually able to deliver high flow, very high flow rates. And this air, or it can be oxygen, is warmed and humidified before it enters the patient. And it's delivered by this very soft nasal cannula. And like I said, it's delivered at very high flow rates, up to 60 liters per minute. So I don't know how many of you have actually tried this. It's actually really it makes you feel quite nice. It actually makes me feel sleepy, and I tried it while I was awake. And this is actually used extensively in the inpatient setting. And the way that it works is that, first of all, because of the very high flow rates, there is resistance on expiratory flow. So when you're breathing against when the expiratory flow, the high inspiratory flow is offering so much resistance that as you're trying to breathe out against it, it increases the back pressure and therefore airway pressure. So it does generate some airway pressure. It also reduces the anatomical dead space and increasing the CO2 washout. And that's essentially some of the key mechanisms of action. And in terms of cardiopulmonary changes that are evident when you're using high flow, there's improvement in oxygenation, decrease in CO2, there's a decrease in both heart rate and respiratory rate. But what there's also observed is decrease in work of breathing, as well as an increase in lung volumes. And the big advantage of high flow, and again, it's like I said, most of the experiences in inpatient settings is that it's the comfort of the interface. It's not a tight-fitting mask. We're able to deliver for those children that need it, and adults, high flow oxygen, very high rates of oxygen, and that you can eat and you can speak using high flow. So you can actually use it during wakefulness as well. And just to highlight again, for those who may not be familiar, it's used extensively in preterm infants in the NICU. It's become pretty much standard of care for children with moderate to severe bronchiolitis in inpatient settings. It's also used in children with respiratory distress and failure. And then in adults, both with hypercapnic and hypoxic respiratory failure. And then actually is used in ambulatory settings in adults with COPD. And probably many of you know that high flow or AirVo really became a first line of treatment for many of the COVID patients who were transitioning to ICU. So this was provided to patients. So it has a high efficacy, partly because it's very well tolerated. And so the question has arisen, could this be efficacious for the management of OSA? And I know the first question people will ask is, well, it's an open circuit. It doesn't deliver that much pressure. How can this be managed or be effective for the management of OSA, which, you know, in some of our patients, CPAP pressures of 15 to 20 centimeters of water just to keep the airway open. And so, and many of you are absolutely right. So here I went on sabbatical to the Neuroscience Research Institute of Australia in 2017 because I was deeply interested in trying to understand how high flow therapy works. So here I conducted a study. It was in adult patients, and our main question was, what was the positive airway pressure generated during high flow, as well as was there genioglottal muscle activation? So here's a very compliant adult patient. He was actually one of the PhD students in the Neuroscience Institute with Danny Eckhart, where I did my studies. I just want to highlight we had choanal catheters and epiglottic catheters here to measure airway pressure. And you probably can't see here, I'm trying to highlight it, but we actually instrumented the genioglottal muscle, you know, so sticking needles into the tongue here just to see what happened to genioglottal muscle activity with high flow. And these were in awake patients, majority of who didn't have obstructive sleep apnea. And what we did was we incrementally increased the high flow pressures from 0 to 60 and looked at, as I'd mentioned, in the non-heated and heated conditions just to see what happened, and measure genioglottal muscle activity and airway pressure. So I'll start off by saying there was no changes in genioglottal muscle activation, but these patients were awake. But you can see here, both in the non-heated and the heated conditions, there was a significant increase in airway pressure with a median of around 6 centimeters of water, although there was variability at 60 liters a minute. So not that much pressure if you compare it to what is delivered during CPAP. But again, you know, we come back to this question, can we improve OSA using heated high flow therapy? So here's a study undertaken in children by Stephen Hawkins out of Denver. And this was a retrospective study. And what they wanted to look at was whether high flow was effective in children with OSA, all of the children who were intolerant of CPAP. And during a PSG, what they did was they provided high flow and they traded up to a maximum of 50 liters per minute to see if it got rid of the OSA. And they compared that to a baseline PSG study that had been done. And again, there was a mixture of children with medical complexity and obesity as well. And here's what they found. So I'll just show you here, the y-axis is the obstructive events per hour, and the x-axis is a diagnostic study, and then they compared that to the high flow titration. I think you can see there's the obstructive apnea-hypopnea index, obstructive hypopnea index alone, and then the obstructive apnea index. I think overall, you can see there was a significant reduction in OHI using optimal high flow pressure. So they were titrated during the sleep lab. And the device was really well tolerated during the sleep lab. But I think one thing I just want to highlight in this study was that they didn't necessarily ameliorate the oxygen desaturation, as 4 out of 10 of these children required oxygen on top of requiring high flow therapy. But as we mentioned, right, that this was a small study, it was retrospective as well, so but very promising early data around potential use of high flow in children who don't tolerate CPAP. And so following on from the work I'd done on my sabbatical, I came back and I really wanted to investigate this in a more robust manner. So we decided that we needed to really know if high flow, how it compared to CPAP in the management of children with both complex medical conditions and obesity. And this was a randomized non-inferiority crossover design. And we compared the change in the obstructive apnea-hypopnea index when we used high flow compared to when we used CPAP. So we recruited patients who had an OHI more than 5. We sent everybody off to ENT to make sure that there was no surgical intervention that we could do instead of giving CPAP or high flow. And only if the surgeon said, you know, there's no surgery to be done here, go ahead, did we go ahead. And all of these kids had 2 studies. They had one with a high flow titration, and then they had a second study with a CPAP titration in random order so that we could actually compare them. And any, for the physicians that were reporting the studies, physicians either reported the CPAP studies or the high flow studies, so they weren't aware of what happened in the other study. And in this study, we were powered to recruit 18 children. So we recruited 18 children. And you can see here that 72% had a previous adenotonsillectomy, and 9 had medical complexity, and 9, and there was quite a diverse population here. And then I'll just talk you through here. So I just want to remind everybody, we're comparing the change in OHI using high flow versus the CPAP from the baseline. And what you can see here, when you look at the OHI here, there was a significant difference from the baseline in high flow compared to baseline as there was in CPAP. And the difference in CPAP and high flow was the same. So right now, high flow was equivalent to CPAP in reducing the AHI. It was equivalent, high flow was equivalent to CPAP in improving the nadir oxygen saturations, and it was equivalent to CPAP in reducing the arousal index. And when we look at the graph here, so we're looking at the differences from the baseline measures here. So you can see here, this is high flow is in red and CPAP is in blue here. There was equivalent difference in the arousal index, equivalent increase in the oxygen, nadir oxygen saturations, and equivalent decrease in the apnea-hypopnea index. So I think what we were able to see here is that we know that high flow doesn't generate the same pressures as CPAP. So the mean CPAP pressures were at 8 to 9 centimeters, and I've already mentioned high flow probably can only generate 5-6 centimeters of water. But what we did see that none of these children required additional oxygen, and that it was equivalent to using CPAP. What we don't know though, and by the way, it was very well tolerated, we don't know what would happen in the home setting. What would the adherence look like? What would the tolerance look like? Would that eventually be the same as CPAP, that they didn't wear it and it wasn't tolerated very well? We don't know. But we are going to go to the next phase of this, where we're going to conduct a multi-centered randomized controlled trial in the home to try and answer these questions, but with a particular emphasis on looking at adherence, tolerance, but also, does it improve the clinical symptoms? Does it improve the quality of life? And importantly for children, does it improve neurocognition? Some of the challenges, of course, that are not evident with CPAP, but are clear with hypotherapy is it's not battery operated, and the portable mode is for 20 minutes only, and that's in the transport mode. We don't know how to monitor adherence. There's no inbuilt adherence mechanism. And of course, currently the costs are really high, around $3,500, with consumables that cost around $100 a month as well. So a financial burden on our families, as well as the fact that it's not portable. So what else do we have for these children? So again, positional obstructive sleep apnea. Again, adult colleagues are much more familiar with positional obstructive sleep apnea, and it's really only gaining traction here in children, I would probably say, in the last few years. And just quickly to say, this is a distinct clinical phenotype where obstructions occur predominantly in supine sleep, where the OHI is at least twice in supine sleep versus non-supine sleep. And again, very recent data, probably in the last 4 years, has shown that positional OSA is actually quite prevalent in older children with obesity. And in fact, a study done in our center showed that 58% of our obese adolescents who had moderate to severe OSA met the criteria for having positional obstructive sleep apnea. And the prevalence of positional obstructive sleep apnea was a little bit lower in some of our younger children. And positional obstructive sleep apnea, when present, tended to be milder than those who did not have positional obstructive sleep apnea. And again, many devices, I've learned a lot from my adult colleagues about all of these new generation devices with gentle vibration feedback, which prevents adoption of the supine position. And many of these devices now also able to offer objective adherence data. I don't know if anybody's using these devices in children, but right now in children, we are focused on these inflatable devices. They're simple, they're easy to use, they're quite cheap, but there's no way to measure adherence in these devices. And I just want to show you some work by Dr. Lena Zhao, who's an early career researcher and just completing a sleep fellowship at the Hospital for Sick Children currently. And so during her fellowship, she actually undertook a study in 10 children, so a small study, where she actually looked at what happens to children with positional OSA who wear a positional device. And what you can see here, so every child following their baseline study had a second sleep study with a positional device with a sleep technologist who really had and was familiar with using positional devices in adults. And you can see here on this first figure here, there was a significant reduction in the OHI using the positional device compared to the baseline device. But I want to highlight this patient here, where it didn't really work that well. Even though there was a reduction in AHI, this patient was left with significant OSA. Not surprisingly, there was a significant reduction in supine sleep. And again, there wasn't a significant reduction in oxygen desaturations, but again, I think this was a reflection of power, as most children did have improvement in their oxygenation indices. So that was a small amount of data, and Dr. Zhao is actually now conducting a randomized control trial in children looking at the efficacy of a positional device in children. But one of the things that, when we're talking to our colleagues as well, is that we have now, as part of all our templates and part of all our indices, and thank you to Colin Massicott, who's really led the efforts at Sick Kids, whereby now we document the presence of POSA on every single one of our sleep studies. It's including in our report, so it really is evident to us who has positional obstructive sleep apnea. And why we think this may be a really practical device is not only it's comfortable, cost efficient, it's non-invasive, but it really, really may be a treatment which may not be fully effective, but maybe at least partially effective for many children who do not have access to comprehensive sleep services. So there's a lot of work to be done here. And I think it'll be really important for us to see the results of Dr. Zhao's randomized control trial, just to see how effective this therapy is. Finally, I'm just going to end with hypoglossal nerve stimulation. I have no experience in hypoglossal nerve stimulation at all, but this was again highlighting a randomized controlled trial of hypoglossal nerve stimulation in the US. And in this one, the hypoglossal nerve is stimulated by an external device during sleep. And what that does is it promotes tongue protrusion during inspiration, opening up the airway and therefore helping to eliminate upper airway collapsibility. And in this study, again, mentioned this was a randomized control study in the US, and after 3 years, 2/3 of the adults who were given hypoglossal nerve stimulators, 2/3 of them that had severe OSA showed sustained benefits, not just in reductions of OSA, but also had decreased sleepiness, decreased snoring, and improved quality of life. And I remember looking at this thinking, well, this is so great. It's like super expensive. This will never happen in children due to its highly invasive procedure, and also the fact that it's hugely resource intensive. And I was wrong, actually. And here's a study published in 2020 in children with Down syndrome who were highly selected. So these were children who were not wearing their CPAP. They were mostly non-obese, and most of them had not significant limitations in their neurocognitive abilities. And here what you can see in these 20 children, there was a significant reduction in the OHI after a few months after implantation. But I think the key here for this thing, that this device was really well tolerated, and they were using this device 9 hours a night. So the device actually has to be switched on and off, and it was tolerated. And some early data, and there's more data to come out from this group, shows actually that there was a significant improvement in symptoms and a significant improvement in quality of life, not just for their children, but their families as well. So, you know, I know Dr. Probst, who's our ENT surgeon at Sick Kids, who has, you know, led many of these advanced surgical efforts at Sick Kids, but also in the province, is keen to have this device here for some of our children who have some of the most resistant OSA and are non-adherent to CPAP. So I'm going to summarize here because I'm probably out of time as well. But I think we all are beginning to understand that OSA is a heterogeneous disorder and is prevalent in a heterogeneous group of children, and that our traditional one-size-fits-all approach, such as CPAP, is really not valid. And that, you know, how we're going to really understand what treatment is going to best benefit our patients is that we need to better phenotype OSA in terms of risk factors, pathophysiology, clinical presentation, comorbidity, as well as patient preferences and family preferences for therapy. And only when we have this phenotyping can we really direct and personalize the care of children with OSA. With any of these therapies that we're talking about, you know, we're at the very early stages, and I think we can all agree that they really need to be rigorously investigated before they can be applied more generally. And, you know, what do I think the future would look like for many of these children is that they would be diagnosed with a persistent OSA, and then we would be able to easily phenotype them based on work that is being done. We would then take into account patient preferences, and that we would be able to direct the therapy here. And, you know, there's so many therapies I haven't talked about. We know there's a lot of work going on in orthodontics and myofunctional therapy as well, work coming out of the USA. Haven't talked about, you know, some of the novel pharmacotherapeutics such as oxybutynin and atomoxetine, although we do understand nasal steroids and montelukast are probably only beneficial for mild OSA. But really trying to understand or take into account patient preferences for therapy, availability of therapy, and also that some of these therapies may not be used as monotherapies, but we may require combination therapies, but that we really need to work towards this goal of trying to treat these children in childhood to really optimize their neurodevelopmental, psychosocial, physical, and mental health outcomes in adulthood. I'm going to end there. I have a whole group of people that I work with. None of this work is possible without my team. I'm just one part of the team. And I work with this incredible team, especially the entire Sick Kids clinical team, who have all been part of this work. And of course, the Canadian Sleep and Circadian Network, and of course, all my funding organizations. So I will end there and happy to take any questions. And thank you so much for listening. I know that was quite a long presentation.
Thanks, Dr. Narang. Can you hear me okay?
Yes, I can.
Thanks. Perfect. That was excellent. Very good overview of what we can offer children outside of CPAP. Just a quick question regarding DICE. So, you know, we know it's not particularly available in the province. In terms of multi-level intervention at one time, I find some of my colleagues in ENT in the community will do adenotonsillectomy and inferior turbinate reduction at once. Outside of that, which I think is reasonable, if you've got big inferior turbinates, why not do it all at the same time? Outside of that, do you find with the DICE approach that they'll attack even additional levels of obstruction? And the reason I ask the question is because outside of inferior turbinate reduction with adenotonsillectomy, I'd be weary of moving ahead with a tongue-based reduction or lingual tonsillectomy without doing those more simple procedures in terms of the associated, post-operative course. And I remember Dr. Props telling me that lingual tonsillectomy at the same time as adenotonsillectomy can result in scarring that can be concentric and in fact worsen airway patency. So just your thoughts on, does DICE offer additional benefits versus just empirically taking out big inferior turbinates at the same time as adenotonsillectomy?
You know, Sunny, that's a great question, and that is the question that the US group are trying to answer in their randomized control trial. I can tell you there's a very pro group saying take out what you can, whether that's a single approach or a stepwise approach. So I think I agree with you. They are doing adenoids, tonsils, and inferior turbinate. Seems to be like a first line approach, with many going in to do DICE and doing lingual tonsillectomies, for example, as a second line approach, with much fewer doing tongue-based reductions. I mean, it seems in the US, the tongue-based reductions is definitely a second procedure, not a first procedure, which I actually think is reasonable. You don't want everything done in one go. But there are many who are advocating that if you're going to do adenotonsillectomy, just do DICE at the same time as your adenotonsillectomy as well. So at least you know as well what may be potential sites of obstruction for future surgeries. Does that make sense?
Yeah, absolutely. I guess what I was trying to get at is, in the absence of the availability, I wonder if it's a reasonable expectation or discussion to have with ENT in the community to say, you know, if the turbinates are big, just take them out at the same time as the adenoids and tonsils, sort of on spec. The same way we would advocate for adenotonsillectomy versus just adenoidectomy, which was done historically. Does that make sense?
Yeah, and I think some of our ENT colleagues are actually already doing that. Is my understanding. I know that they're pretty gung-ho in the US, but I know that they're doing it here.
Excellent. Yeah, and I find it's a mixed bag. I appreciate when they do it all at one time, though, for sure.
Yeah.
Perfect. Thanks.
And there is a comment.
Hi, this is Dr. Mark Carey, and I'm ENT in Scarborough. May I speak?
Yes, please do. We would love your opinion.
Yeah, so very nice talk. Thank you very much. Very comprehensive. Yeah, so in my practice, at least, So I do find, especially in the very young kids, the inferior turbinate nasal obstruction part is significant. Even if you take out, their adenoids, tonsils, sometimes even the anterior and posterior part of the inferior turbinate does make a big difference. So, I don't do DICE, but that is very helpful in terms of their nasal obstruction part.
Yeah, and maybe Dr. Malkanian, you can, talk to this, but I've noticed that in the last few years, there's a lot more turbinate reduction happening than there was previously. Has that been your experience as well?
Yes, so like I say, it does make a big difference. So I have been doing it more frequently. And so the inferior turbinectomy, the anterior part is quite easy to do. It just takes about 5 minutes. But during the adenoidectomy as well, just doing the reduction of the posterior bulbous part of the inferior turbinate also helps. Because you can imagine the adenoids and the nasopharynx is all chronically inflamed and congested. So those turbinates do remain large, and also using the nasal steroids post-operatively, once the adenoids are gone, putting them on nasal steroids for a while also shrinks them down. That also helps, I find.
Great, so now I know who to send my patients to. Are there other questions? Happy to answer any questions.
I have a comment, not a questions. For kids who are obese or any motivation, I usually don't give them money, but I tell the parent to either set a bank account or make account for them to look forward, and then either they use it for something big for them or use for college. So I put it in the family's hand rather than me give them the money. So anyway.
Yeah, I do usually, but I have to take it with this one child. I was kind of desperate, and I just wanted to see, because I guess in my mind, if he was going to wear it 30 days, he was now going to continue to wear it. And it just showed you how wrong I was. And actually, these adolescents will outdo me every time. It was a real learning experience for me.
Question. This is maybe a bit of a selfish one. Your thoughts on a 1 to 3 day course of oral dexamethasone in children with severe OSA who are awaiting adenotonsillectomy, but are waiting and have relatively profound OSA and are 1, 2, 3 years old?
Okay, I'm really pleased you asked me that question, because I don't know if we are conducting a randomized control trial right now. We're randomizing children with a moderate to severe obstructive sleep apnea post PSG to 3-day course of oral dexamethasone. And then these children are getting a sleep study at 2 weeks. Sorry, they're getting a full ENT assessment as well. And they're getting a sleep study at 2 weeks, and then a sleep study at 6 months if no intervention has taken place before 6 months, because I'm not sure it's going to cure the OSA, but I am hopeful that it will buy us time, both in terms of what we see on a PSG, but also symptoms as well. So that trial is underway at Sick Kids. So watch this space, but do I believe that it has a role? Yes, I do. And that's my anecdotal evidence, which led to this randomized control trial. And then just to try and understand a little bit more of how it might work, we're actually taking nasal epithelial cells from these children with OSA who've been given dexamethasone, and we're comparing the inflammatory profiles before and after dexamethasone. In a similar way that they've done with nasal steroids. But do I think it has a role? Yes.
Excellent, thanks. I didn't know you were doing the study, but the literature is conflicting, and we're looking for anything that can temporize. So that's awesome to know it's in the works.
Yeah, and again, that has come up because there are people in rural areas who don't have the same access of significant symptoms. So we can do oximetries, but it takes a while to get them to have sleep studies. And so my goal is that we have something other than nasal steroids that we can give to some of these families.
Excellent.
And there is a question as it is, do we have to send all cases of Down syndrome for a sleep study? So, you know, the American Academy of Pediatrics believes that every child 3 to 4 years of age with Down syndrome should have a sleep study. That is not what I necessarily say. That was not based on evidence. We know that there are many children where it's obvious they have obstructive sleep apnea, they have big tonsils and adenoids, and our ENT colleagues are taking out the adenoids and tonsils without a sleep study. I guess the question is, if there's residual symptoms after, do they need follow-up, you know, to assess both the symptoms and then maybe a PSG? Probably, but I personally, I don't know what you think, Dr. Bowler, and some of the others. I don't think every child needs a sleep study to have the tonsils and adenoids out.
Excellent. Perfect. Thank you very much, Dr. Narang. That was an excellent talk, and I think we all enjoyed it. Thanks again.